Welcome back to the deep dive. Today we're tackling a topic that, let's be honest, usually serves as the punchline for bad jokes.
Or those really awkward commercials.
Right, exactly. But in the clinical setting, it is absolute serious business. Today we are breaking down Chapter 46, Urinary Elimination.
It really is serious business. And honestly, it's one of those chapters in Potter and Perry that students tend to skim.
Because they think they already know it.
Right. They think, okay, I know how peeing works. I've been doing it my whole life. But then, they get to the hospital floor and they realize that urinary elimination is actually this massive window into a patient's systemic health.
It's connected to everything.
It really is. It involves hemodynamics, neurology, skin integrity, even cognitive function. It is surprisingly complex.
And that is exactly our mission today. We really want to move past that sort of checking the box bathroom break mentality and understand the actual nursing process here. We have a lot of ground to cover.
We do.
From the detective work of assessment to the high-stakes hardware of catheterization.
And we definitely need to talk about dignity. Because if you mess up this part of care, you aren't just risking infection.
You're risking a lot more.
Yeah, you are potentially stripping a patient of their self-worth. It's an incredibly vulnerable thing.
So let's get right into it. The source material starts, as the nursing process always does with assessment. But Chapter 46 throws a curveball immediately.
Yeah, it does.
It suggests that before you ever touch the patient or look at a sample, you have to assess the patient's eyes. What exactly does that mean in this context?
It basically means you have to read the room. I mean, urinary issues are deeply private in many cultures, and honestly, for most individuals, just the idea of needing help to urinate is humiliating.
Right, it's a huge loss of independence.
Exactly. So the patient's eyes concept is about assessing their psychosocial state first. Are they anxious? Are they confused? Do they even understand what a catheter is or why they might need one?
Because if you just walk in there treating it like a mechanic changing oil,
You're just looking at the parts and not the person. If you do that, you have already failed the assessment.
that's a really great way to put it. You have to establish trust before you establish a sterile field.
Precisely.
But eventually, we do have to get clinical. The text outlines a specific physical assessment map. So if I'm the nurse walking into the room, walk me through the geography here. Where am I looking and touching?
Well, you're mapping the tract from top to bottom. So you start with the kidneys. Now, you aren't going to see them, obviously, because they're retroperitoneal.
Tucked away in the back.
Right. But you are checking for costovertebral angle tenderness, which is often called CVA tenderness.
Okay, let's unwrap that jargon a bit. CVA tenderness, how do we actually find that?
You find the angle formed by the spine and the 12th rib on the patient's back. You place one hand flat on that spot and give it a firm thump with your other fist.
A thump. That sounds a little aggressive.
It's firm, but it's not damaging. If the kidneys are healthy, the patient usually just feels a dull thud. But if there is inflammation or an infection...
Like pyelonephritis.
Exactly like pyelonephritis. If they have that thump causes intense pain. If the patient jumps off the table or grimaces, that is a positive sign. It distinguishes kidney issues from just regular back muscle pain.
Got it. So kidneys first, then we move down the track to the bladder.
Right, and anatomy really matters here. A healthy, empty bladder sits below the symphysis the pubic bone. You shouldn't be able to feel it at all.
Because it's tucked away.
Yeah, it's tucked securely away. But if a patient is retaining urine, that bladder can rise up significantly.
How high are we talking?
It can extend all the way to the belly button, the umbilicus, especially in severe cases. When you palpate it or lightly press on it, it will feel like a smooth, rounded, firm mass.
And I imagine the patient will have something to say about that.
Oh, definitely. They will likely tell you it feels uncomfortable or that they have this intense urge to go. If you feel that distension, you know right away you have a retention problem.
And then inevitably we get to the exit points, the external genitalia and the urethral meatus.
Yes. And here you are looking for the obvious signs of infection, inflammation, discharge, lesions. But the source material emphasizes something else critical here. Skin integrity.
Yes, specifically the perineal skin.
This connects directly to the impaired skin integrity risk we see in so many of these care plans.
Exactly. Urine is highly acidic. It's waste. If a patient is incontinent and that urine just sits on the skin, it causes maceration.
Which is when the skin gets all soggy.
Right, it gets soggy, soft, and starts to break down. That is a fast recipe for pressure injuries and secondary infections. So you are constantly assessing, is the skin red? Is it raw? Is there a rash?
That tells you how well their incontinence is being managed. Or if it's being managed at all.
Precisely.
Okay, so we've assessed the patient physically. Now let's look at the product itself, the urine. The text gives us three main characteristics to watch: color, clarity, and odor. Now, I feel like color is pretty straightforward. Yellow is good, red is bad. But looking at the source, it seems a little bit more nuanced than that. It is more nuanced. Pale straw to amber is the normal range, and that largely depends on hydration. But you really need to watch for the extremes.
Like what?
If you see dark amber or a tea-colored urine that signals high concentration, it could be severe dehydration, or it could actually be liver issues where bilirubin is spilling into the urine.
Oh, wow. And red isn't always active bleeding, right?
Correct. Bright red definitely implies active bleeding, perhaps from the bladder or urethra. But rusty or dark red urine might be older blood coming from higher up, like the kidneys.
Or they just ate something weird.
Exactly. Frankly, it could be that the patient ate a lot of beets or blackberries. You always have to ask the dietary questions, too.
Good point. What about clarity?
This is a huge one for early detection. Normal urine should be transparent at the exact moment of voiding. You should be able to see right through it.
And if you can't?
If it comes out cloudy, foamy, or thick, you have to suspect bacteria or white blood cells are present. That cloudy appearance is very often your first visual cue of a urinary tract infection, long before the lab results even come back.
That's a great clinical pearl. And finally, odor. The text mentions a sweet or fruity odor as a specific red flag, which sounds pleasant, but I assume in this context it's really not.
Not at all. A faint ammonia smell is perfectly normal. But a strong, pungent ammonia smell usually means the urine has been sitting there for a while.
Like in the bladder due to retention.
Yes, or maybe in the bed sheets. It's stagnant. However, that sweet, fruity scent you mentioned, that is actually incredibly dangerous.
Why is that?
That usually indicates the presence of acetone or ketones, which are byproducts of incomplete fat metabolism.
Like a diabetic ketoacidosis.
Exactly. You see this in uncontrolled diabetes or starvation. That's a major metabolic alarm bell ringing. If you smell fruit, check the blood sugar.
It's amazing how much data you can get just from looking and smelling. And then, of course, we had the hard data, intake and output, I and O.
The accountant side of nursing.
Right. Why is this emphasized so heavily in the chapter?
Because you need to verify that the fluid going in mathematically matches the fluid coming out. It's a balance sheet.
Makes sense.
If a patient drinks 2 liters of water, but only voids 500 milliliters, and they aren't sweating profusely, you have to ask, where's that liquid going?
Is it retaining in the tissues?
Right.
Yeah.
Is the heart failing to pump it to the kidneys? Is the kidney failing to produce urine? Intake and output is really a vital sign in its own right for assessing overall organ function.
So we've gathered our clues. We have the flank pain, the cloudy urine, the I and O data. Now we have to actually name the problem. This brings us to diagnosis. The source lists several specific nursing diagnoses, but I want to focus on incontinence.
That's a big one.
Because I think lay people view incontinence as just leaking. But the text breaks it down into very distinct mechanical problems.
It is definitely not one size fits all. And understanding the specific type of incontinence is the only way you can actually fix it. If you treat all incontinence exactly the same, you will fail.
Let's run through the main ones mentioned in Chapter 46. Let's start with functional incontinence. This one really fascinated me.
Okay, picture a patient who has a perfectly working bladder. Their nervous system works, their muscles work perfectly, but they have severe arthritis in their hands and can't unbutton their pants fast enough.
Oh, I see.
Or maybe they have dementia and simply can't recognize the symbol on the bathroom door. That is functional incontinence.
So the urinary tract is fine. The problem is access or cognition.
Exactly. So the fix there isn't medicine. It's giving them elastic waistbands or putting up better signage. You modify the environment, not the bladder.
That is such a distinct difference. Compare that to stress incontinence.
Right, so stress incontinence is purely mechanical. Intra-abdominal pressure rises. You cough, you laugh, you sneeze, you lift a heavy box.
And the sphincter just gives out.
Right, it just can't hold the seal against that sudden pressure. You get a small leakage. We see this a lot in women after childbirth due to weakened pelvic floors. The support structure just isn't tight enough to withstand the pressure spike.
Sometimes called the giggle leak.
Yes, exactly.
And that's very different from urge incontinence.
Very different. Urge is the overactive bladder. The patient gets a sudden, intense signal that they need to go right now. There is no warning whatsoever.
So it's not related to a sneeze or a cough.
No, the bladder muscles just spasm. They might not make it to the bathroom, even if it's only 10 feet away. It's not about pressure. It's about a lack of control.
And then the text mentions reflex or overflow incontinence.
These are often neurological in nature. With reflex incontinence, think of a spinal cord injury. The brain just isn't receiving the full message.
The bladder just keeps filling.
It fills up, and when it hits a certain stretch point, the spinal cord reflex just dumps it. There is absolutely no conscious control.
And overflow is similar.
Overflow is similar in that the bladder is overdistended and the internal pressure just pushes small amounts of urine out just to relieve the tension. But the bladder never actually fully empties.
So if you apply the critical thinking model the text talks about, you can't just treat incontinence as a blanket term. If you treat a functional incontinence patient who really just needs help with their buttons with the medical protocols for reflex incontinence, you aren't helping them at all.
In fact, you might make it much worse. You have to synthesize the knowledge of the anatomy with the specific story of the patient. That is the analysis part of the nursing process. You have to ask, why is this happening, before you decide, what do I do?
Well, speaking of what do I do, let's move to the part that makes everyone a little nervous. Implementation. Specifically, acute care and catheterization.
Ah, the hardware.
The hardware. The source material has these incredibly detailed cross-section diagrams of catheters. And I realized going through it, I didn't actually know why there were different types. I always just thought a tube was a tube.
Not quite.
Let's start with the straight catheter. Image A in the text.
The straight cath is a single lumen tube. Basically, think of it as a straw. It has one job: go in, drain the bladder, and come straight out.
So it doesn't stay in.
No, we use this for obtaining a sterile urine specimen if the patient can't void on their own, or for immediate relief of severe retention. But it does not stay in the patient. It's completely in and out.
Simple enough. But then we have the indwelling Foley catheter, image B. This one stays in. How does it not just fall right out?
If you look closely at the cross-section, you'll see it's a double lumen. One channel is the straw. It drains the urine.
And the second channel.
The second channel connects to a small balloon at the tip. Once you insert the catheter all the way into the bladder, you use a syringe to inflate that balloon with sterile water, usually about 5 to 10 milliliters.
So the balloon acts as an anchor.
Exactly. It anchors at the neck of the bladder so it physically can't slide back out through the urethra.
Okay, that explains the two holes perfectly. But then I saw image C, the triple lumen catheter. And I thought, what on earth is the third hole for? This looked like heavy machinery.
This really is the heavy artillery. You usually only see this after urological surgery, like a prostate procedure or a bladder tumor resection.
Walk through the lumens with me.
Okay, lumen 1 drains the urine. Lumen 2 inflates the balloon. And note, in these triple lumens, the balloon is often much bigger, like 30 milliliters, because they use it to apply direct pressure to start bleeding.
Makes sense. And the third?
The third lumen is for irrigation. This allows us to pump sterile fluid into the bladder while the other line constantly drains it out.
Wait, why would you want to pump fluid in?
To flush it. If a patient is bleeding internally after a surgery, you might have blood clots forming inside the bladder.
And a clot could block the tube.
Exactly. If a clot blocks the catheter, urine backs up, pressure builds, and you have a severe medical emergency. The irrigation creates a continuous flush to wash out those clots and keep the plumbing totally clear.
That is incredibly clever engineering. But the text pivots sharply here to a very serious warning. It talks about surgical asepsis.
This is undoubtedly the most critical safety point in the entire chapter. Listen, the urinary tract is sterile. The minute you introduce a plastic tube into it, you are basically building a superhighway for bacteria to travel straight into the body.
Catheter-associated urinary tract infections, COEDs.
Yes. CIUDs are one of the most common and dangerous hospital-acquired infections out there.
So this isn't just a wash your hands and put on regular gloves situation.
Absolutely not. This is sterile gloves, sterile drapes, sterile technique. You are setting up a strict sterile field. If your catheter tip touches the bedsheet or your own leg or the patient's thigh before it goes into the urethra, you stop.
You don't try to clean it.
No, you throw it away. And you start completely over with a brand new kit. You simply cannot compromise on this.
That sounds incredibly high pressure. And on top of that, the text flags allergies as a major safety stop, specifically latex and iodine. Why are those the big two?
Because they are standard in almost all the kits. Most standard catheters are made of latex, and the cleaning solution provided in the prepackaged kit is usually povidone iodine.
Betadine.
Right, betadine. If you don't check the patient's allergy history before you open that kit and you insert a latex catheter into a sensitive patient, you could trigger full-blown anaphylaxis.
Severe shock.
Severe shock. Or if you scrub them with iodine, you cause a massive, painful skin reaction.
So what's the workaround? Because you still have to catheterize them.
You have to be prepared and check the chart. If they have a latex allergy, you grab a 100% silicone catheter instead.
And for the iodine.
If they're allergic to iodine or shellfish, which is often a related cross-allergy, you use chlorhexidine for the cleaning step. It's a really simple switch, but you have to know to make it before you start.
Safety first, always. Now let's assume the catheter is in safely. The text talks about maintaining a closed drainage system. Why is it so vitally important to keep it sealed?
It goes right back to that bacterial highway we talked about.
Yeah.
The bag and the tube form a sealed loop. Every single time you disconnect the tube to take a sample or change the bag, you literally open the door for bacteria to enter the system.
So the rule is keep it closed.
Keep it closed, and also keep the bag below the level of the bladder.
Just simple gravity.
Gravity is your best friend here. If you lift the drainage bag above the bladder, the urine and whatever bacteria is multiplying in it flows straight back into the patient.
And that is a guaranteed infection.
100%.
Okay, so that is the acute phase, the hardware phase. But obviously, we don't want patients on catheters forever. The ultimate goal is to get them back to normal. Let's talk about the final segment, restorative care and health promotion.
Right. We want to remove the catheter as soon as clinically possible, and then we need to help them regain their normal control.
The text mentions promoting normal micturition, which sounds really fancy. But looking at the interventions, they seem surprisingly low-tech.
They are very low-tech, but they are high impact. I mean, think about it. Can you pee easily lying completely flat on your back in a strange room with strangers walking by the door?
Absolutely not. It's basically impossible.
Exactly. So restoration starts with simple positioning. Use gravity to help. Have men stand up if they are safely able to. Have women sit upright on a bedside commode rather than struggling on a bedpan.
The text also mentioned running water.
Yes, run the water in the sink. The sound suggests the action to the brain. Give them privacy, close the door, pull the curtain. These are fundamental nursing interventions that don't need a doctor's order, but they can absolutely be the difference between a patient voiding successfully on their own or needing to be recatheterized.
What about fluids?
Push fluids. Unless they have heart failure or kidney failure where fluids are strictly restricted, you want to flush the system. 2,000 to 2,500 milliliters a day helps wash out bacteria and prevents the urine from getting too concentrated and irritating the bladder wall.
Now, for those patients dealing with that stress incontinence we talked about earlier, the sneezing and leaking, the source strongly emphasizes pelvic floor muscle training. Kegels.
Yes, and it's great that the text provides diagrams for both male and female anatomy because this absolutely applies to both. It's all about strengthening the muscles that support the urethra and the pelvic floor.
Is it a quick fix?
Not at all, and the nurse really needs to manage expectations here. This isn't an overnight fix. It's essentially physical therapy for your pelvic muscles. It takes weeks or even months of daily dedicated practice to see real results.
What about bladder retraining? That sounds like sending your bladder to boot camp.
In a way, it really is. This is specifically for urge incontinence. If a patient feels the need to go every 30 minutes, the bladder actually shrinks over time and gets used to that very small volume.
It becomes hypersensitive.
Exactly. So retraining involves a very strict schedule. You say, okay, you are going to wait exactly 45 minutes.
Even if they feel like they desperately have to go.
Yes. You teach them to use deep breathing and relaxation techniques to actively suppress the urge. You stretch that time out, then you extend it to an hour, then 2 hours.
So you're retraining the brain and the bladder at the same time.
You are physically stretching the bladder's capacity and cognitively helping them regain control over that urge mechanism. It's incredibly effective, but it requires a lot of discipline.
And for those where the plumbing just won't work effectively anymore, or where putting a tube through the urethra is just too dangerous, the text mentions alternatives, like suprapubic catheters or condom catheters.
Right. A suprapubic catheter is surgically placed through the abdomen directly into the bladder. It bypasses the urethra entirely.
Which seems extreme, but I guess it's safer long term.
It is often much more comfortable for long-term use, like in patients with quadriplegia, and it greatly lowers the risk of urethral damage. And for men, the external condom catheter is a fantastic non-invasive option.
It just rolls on.
It fits right over the penis like a condom, but connects securely to a drainage bag. It catches the urine without ever putting a tube inside the body.
It really highlights that there's a wide spectrum of care here. It's not just diapers or invasive catheters. There are intermediate steps that really prioritize and preserve dignity.
Absolutely. And that really brings us back to the core philosophy of this entire chapter.
Let's wrap this up. We have gone from inspecting the clarity of urine to choosing a triple lumen catheter for irrigation, all the way to teaching pelvic floor exercises. It's a huge technical journey.
It really is. But if you look at the nursing knowledge base diagram in the text, it synthesizes all of this beautifully. It's science. You have to know the anatomy and the chemistry of urine. It's safety. You have to absolutely master asepsis and allergy protocols. But it's also art.
The art of truly understanding the patient.
The text explicitly says in the evaluation phase, evaluate through the patient's eyes. You can have a perfectly balanced fluid sheet. You can have crystal clear yellow urine. But if that patient is terrified to leave your house because they fear an accident or if they feel a deep sense of shame every time they look at their catheter bag, have you really succeeded as a nurse?
That is the provocative thought for today, for you listening. Are you just managing a biological function, or are you restoring a person's dignity and self-concept?
In nursing, you really don't get to choose. You have to do both. You are the guardian of their dignity just as much as you are the guardian of their fluid balance.
A powerful reminder. So when you review Chapter 46, don't just memorize the catheter sizes. Look at the logic behind them and the person attached to them. Thanks for diving in with us.
Always a pleasure.
See you on the next deep dive. Stay curious.